So I'm just my topic is about the same, the predictive outcomes in macular after macular hole surgery. So often macular hole surgery is quite rewarding, but we're dealing with good vision, and there's often something to lose after surgery. So accuracy and knowledge is quite important here. So the it is not only to take about taking the right or wrong decisions, but when a patient asks you whether he will get good vision, our most common answer is slightly vague. We just smudge it over there saying you're likely, but it is possible, but it is probable, and it is highly like all these things we say rather than giving definite outcomes. So no presentation on macular hole can go without this slide about the gas classification, which was done brilliantly without the help of OCT. The first question is that do holes close by themselves? So this was the answer. If you have a stage 1 with a VMT and a not full thickness, 30 to 50% of these type 1 and 1A holes could spontaneously resolve. But if it was a stage 2 or a stage 3, spontaneous closure was only seen in 10% of these holes. Once the vitreous connection is totally off, there is no reason for it to close after that. So how can you predict closure rates? Hole closure rates for any hole less than 400 microns is between 92 to 97%. But when it is more than 400 microns, the closure rate with the conventional classic surgeries come down. Again, as the stage of the disease increases 2, 3, and 4, the closure rates come down. So this was a fabulous study on in 2014 regarding a high number of macular holes, and they showed that 3/4 of the macular holes are an improvement in vision. 81% had successful closure. But the things noted were that as the diameter increased more than 1200 at that particular point in 2014, which is slightly before the inverted flap era, the holes did not close, and 3.3 years were given as the mean beyond which operations were not attempted. But in a particular diameter hole, the more duration had a poor prognostic effect. So these slides are just to look at some of the things that we get mental pictures whether the holes will close or not. The first one, when it is flat, when it has no SRF, when it has no RSM, immediately our mind tells us that it's going to be a difficult case to operate. The second one has got RP changes at the base of the hole. Again, we have reservations regarding the outcomes of that particular hole. The top one is a hole that we think is going to close because of the characteristics. These are visual characteristics, a surgeon's instinct, or rather. But there are good preoperative prognostic factors, of which the stage of the hole and the size of the hole are the most important ones. And the less duration of symptoms and a good preoperative vision are features that let us know that there is going to be a good outcome after surgery. But the most essential, simplest measurement is the foramen diameter, minimum foramen diameter, or the minimum linear diameter, measured parallel to the RP, the smallest part of the macular hole. There are quite a lot of studies which again tell us that whatever the other indices come, the best two indices are the minimum inlet diameter and sometimes the relationship to the basal diameter of the hole. This is a new closed study classification which they have added these 2 points in it. The hole size obviously, but the hole edge configuration, whether it is flat or whether it is a cuff of fluid, edematous edges, whether there is cystoid macular edema at the edges, the minimum height, that is the collapsibility of the hole. The greater the height, the more chance that it is going to close. The presence of a VMT and the presence of an ERM has been included inside this closed group classification. And there is a comparison of this classification, and the holes have been defined further: large beyond 400, extra large beyond 550, double extra large beyond 800, and giant beyond 1000. So for larger and larger holes, modified techniques including the inverse flap, the single layer ILM rollover, the temporal hinge flap, the ectopic ILM flap, viscoelastic, and as said in other anything that you can find, you can stuff into the hole. Now we are bored of holes, so we stuff into optic pits now. So that is the basic tendency nowadays. This study was good in a way that it showed us that closure rates with macular holes were high when they were medium to large, but extra large, the closure rates came down. But the closure rates were nearly 100% with the inverted ILM flap technique. So is it a big hurrah that we all start doing ILM flap techniques? We'll look at that later. There are many indices of which the current index, which has seems to have a lot of value, is a macular hole index, which takes into consideration the height of the hole. That is, how much tissue can collapse onto the center of the hole is also taken into consideration. These are the various measurements of the macular hole index, the trapezoid, the triangle. I'm not going to. This is a new paper which has come out, which takes into consideration the tissue around the hole and the cystic areas around the hole, and the MAI. This is by Dr. Ramesh Venkatesh, and he says that the macular hole area versus the total area. The total area is a trapezoid from the top of the hole to the base of the hole, which includes retinal tissue and the hole itself. This was an interesting concept beyond just hole closure. It's called the ELM gap, the gap between the external limiting membrane, found out, which could possibly tell us whether the closure in a closed hole, how deficient are the outer retinal layers. So the ELM gap sign, or the gap, is also a measurable index which tells us more about prognosis. And here you see the ELM gap is high, and there it closes in a flat open configuration with a gap in the center. So this is our paper in which we've used something called the ELM angle. That is the angle between the ELM on both sides. And we got a cutoff level of 68 degrees. When the angle was better than 68 degrees, the ELM tended to close better. And when it is more than 68 degrees, the ELM gap was remaining inside. Choroidal hypertransmission could be just because of the OCT through the hole and increased transmission, but it also could be because of the RP degeneration, and it could be a unique biomarker feature to prognosticate holes. So these are some examples when you see there's increased transmission. The top one, there is tissue over there, but there is still transmission. The lower one, the transmission corresponds to the gap between the retina. NFAS, that is looking at the NFAS image. This is where you see the cystic spaces and around the macular hole. This is again is one of our studies in which we studied a manual segmentation, and we find that two types of cysts. In the outer retina you have more radial oriented cysts, and in the inner retina you have more spec cysts in a larger area. So the outer retinal cysts are in a larger area, probably because of the loss of contact of the RP and the lack of functioning of the RP pump, while the inner retinal changes are more of a chronic nature and are in the Henle's elongated Henle's layer, and both of these were corroborated with preoperative visual acuity. We binarized this and found the areas, and found that there was a correlation between the amount of the cystic area and the preoperative vision. Other good prognostic post-operative features include the integrity of the inner layers and the type of closure. Again, we know there are multiple types of closure. The best one is a type 1 without a defect, and the closure not only corresponds to whether the neurosensory retina is there, but whether the outer retinal integrity is there. Again, these are the type of closures explained, and also the ellipsoid zone integrity, grade 0, grade 1, and grade 2, and obviously the integrity is a main factor for the post-operative visual acuity. This is called a lucency, where you see a small gap despite a closed macular hole. So other features that we find after surgery are the Sandfeld, which is a temporary phenomena because of the surgical trauma, and Dornfeld, which is more associated with ILM peeling, probable amount of dye toxicity and air infusion stress, where the changes are a bit more. There is a loss of the Muller cell plates, and this is beautifully demonstrated as hexagonal circumferential in the area of the ILM peeling on an NFAS OCT, corroborating with a microperimetric changes in these particular areas. So I'm just going to skip these because these are not. Let's talk about the ILM flap. Even though it's a panacea to show the patient you've closed, it is a negative biomarker. When you have a plug, there is no retinal tissue. The visual acuity is less than when the macular hole closes with a classic ILM peel. Therefore, our tendency to go towards the ILM flap should actually be reducing, and not. We have stopped thinking about which holes can close with a regular classic technique, and we do the inverted ILM flap for everything. So this is some of the examples of how the flap, which is essentially not neurosensory tissue, closes the defect. The restoration of the outer retina is something important, is that a good ELM restoration precedes the ellipsoid zone restoration. So the ELM closing is one sign which could tell you in the early post-operative patient period that this patient could get good vision back. As I said, the easy disruption, there is a horizontal value and a area. The preoperative vision is associated with the horizontally measured area, but the postoperative vision is an NFAS measurement of the EZ area. I'll just show you in this slide. You can see this particular slide. After the hole closed, there is still this much ellipsoid zone disruption, and this is responsible for a poor visual acuity after surgery. This is another thing that we studied, is how the fovea moves after surgery, and we found that both the fovea can move temporally after macular hole surgery, and it can move nasally towards a disc, and this could be related to a poor visual acuity. So this is how we measured. We found the preoperative and we found the thing. Metamorphopsia is more associated with the intraretinal cysts, and that could be an indication for estimating the metamorphopsia after surgery. So to summarize, basically we have a lot of features. The preoperative features include the basal linear diameter to be the most important. There are various indices. The postoperative are mainly related to the outer retinal integrity after the surgery, the presence of the ellipsoid, the interdigitation zone, and the photoreceptors. So to conclude, macular holes are neither simple nor are they lost causes. You need careful case selection, a good preoperative OCT to give you clues, and you will get anatomical results. The only thing I'd like to stress is that let's not be too overzealous with the new techniques of inverted ILM flap or stuffing whatever we get inside the macular hole. Communicating with the patient and not giving over enthusiastic results may be important. Thank you very much for that. You can take the questions later also.
Yeah, no. When do you decide to change your routine technique? And based on any of these, what would be the best parameter that you look at? And when do you decide to change the routine ILM treatment?
So I have stopped trying to see. Basically, I'm trying to do more and more classic peels nowadays. So previously, that's all we did, and we had closures. So my range of classic peels suddenly, instead of inverted flaps, we're going down to 400s, for 500s. I'm still doing classic peels, and even when I do the inverted flap, I'm trying to do only a temporal hinge, where the concept is not filling the hole; it's just covering the hole and causing a immediate tamponade after the surgery. So that creates a better sliding of the neurosensory. It's like a combination of the classic peel with just a small thing. So those are the things I'm trying to do in cases where I am compelled to give a good anatomical result after surgery. The ILM goes inside the macular hole.
Now, when you do the temporal flap, you remove the nasal.
I remove the nasal side. It's nearly like a classic, but
Yeah,
there is
only left on the temporal.
only left on the temporal side. Thank you. That was an ROC curve, region area under the ROC curve. So it showed a cutoff area of 68 degrees. So there was a huge number of patients in which we did the ROC curve. On the area, this was the peak at that area.